Hello, good afternoon, everyone. My name is Saki Malak Cho, and I am the Director of Research, Policy, and Health Promotion here at the National Center for Health and Public Housing. I'm joined by my colleague, Vijay Sandoval, and we would both like to welcome you and thank you for attending today's webinar, which is Addressing Violence in Public Housing Communities. We have two really great speakers today, Brian Spikicki from the Genesee Health System and Bridget Luck from Opportunities Industrialization Center. Before we begin the webinar, I would like to go over some housekeeping items that we need to go over first. So the first thing is that the webinar is being recorded, so we've muted all of your lines. We would like to, however, encourage you to ask questions and make comments through the chat function, and you can treat it like a live chat if you'd like. We are really very fortunate to have some seasoned and knowledgeable presenters on this webinar today, and we'd really like for you to get the most out of their time. So it looks like there's a relatively small group of us on the phone today, so there's a lot of potential for a really robust discussion. So we encourage you to post questions and comments through the chat, and then also through the formal Q&A portion at the end of the presentation. So during the Q&A, if you'd like to verbally ask a question, you can use the raise hand icon, and FIDE will unmute your line, and so you can ask a question. After the webinar is over, we'll send you a link to the recording, the slides, and any of the resources that we discussed today in an email. And finally, we'd like to ask you to fill out the post-webinar survey at the end of this webinar. Your feedback is really important to us, and it's not very long, so thank you. So here's the brief agenda for today. We have a real mix of people join today's call from both from housing side and from the health center side. So I am going to provide some background information and context on the health of public housing residents and the need and the importance for establishing violence prevention and intervention programs. And I will also briefly discuss the case study report we just released on violence prevention and intervention programs that are conducted at health centers located in or immediately accessible to public housing. We'll just talk about our approach and our methodology. And then I'll hand it over to our speakers today who also participated in the case study. So our first speaker is Brian Spikicki. He is the Vice President of Business Operations for Genesee Health System, which is located in Flint, Michigan. Brian has been working within the mental and physical health systems for over 30 years, both in a clinical and an administrative capacity. He's led the development of crisis residential facilities, a sobriety facility, the integration of mental health services into the county health plan, and he's also been the CEO of a nonprofit. Right now, he is helping to open a federally qualified health plan operating under Genesee Health System, which will provide primary care to the homeless and to the low-income public housing population in Genesee County. Next, we will hear from Bridget Luck. She is the Program Development Manager at Opportunities Industrialization Center, or OIC Medical, which is in Rocky Mount, North Carolina. OIC is an agency that provides employment and business and health services to the community. In her role, she provides administrative and operations assistance to identify where the gaps are in services and to develop programs and initiatives that improve community health outcomes. She is extremely committed to forming strategic partnerships and collaborations that address the social determinants of health. And she was selected as a 2017-2019 Jim Burnstein Community Health Leadership Fellow, which is a program that helps leaders, develop leaders to work in and improve the health status of rural and underserved communities in North Carolina. As a fellow, she's implementing programs of self-sufficiency that increase access to healthcare for homeless populations and other individuals that are in non-permanent housing. Bridget received her Master of Healthcare Administration and her Bachelor's of Science in Chemistry, both from Winston-Salem. Then after Bridget speaks, we'll have our Q&A portion. And we are hoping that by the end of today's presentations, you'll be able to identify ways that violence impacts the health of public housing residents. You'll be able to describe the components of successful violence prevention and intervention programs, and then you'll be able to list some potential partners to create kind of a holistic violence prevention and prevention programs in your community. I should start by just saying a little bit about the mission of the National Center for Health and Public Housing, which is to strengthen the capacity of federally funded health centers that are located in or immediately accessible to public housing by providing training and technical assistance, research and evaluation, and then services to help build outreach and collaboration. We work directly with health centers and housing agencies to improve access and quality of care and health outcomes for public housing residents. We're funded by the Bureau of Primary Health Care at HHS. However, I should note that the opinions that are expressed here in the presentation are that of the National Center and not of HHS. So for those of you that may be unfamiliar, health centers deliver affordable and accessible and quality, cost-effective primary health care to patients regardless of their ability to pay. There are 1,400 health centers that receive federal funding through HHS, and those health centers provide care for about 26 million people. Of those 1,400, there are 356 health centers that are located in or immediately accessible to public housing. And what that means is that the health center is either located directly on the property or it's like across the street. It's physically close to the development and it can be easily accessed through public transportation. There are 106 health centers that receive special grants called Public Housing Primary Care Grants, which are PHPC grants, that provide care specifically for public housing residents. And we have an interactive map on our website that you can go to if you want to locate either the health centers or the housing development sites that are in your community. As far as public housing goes, there are a little more than 2 million individuals that live in traditional public housing in the U.S. About 60% are female. Almost 40% of the households have children. About half of the individuals don't have less than a high school diploma, and 83% are living at or below the federal poverty level. So I like to start with maps because they're able to clearly show just how location matters. Safe and healthy environments play a large role in determining the health status of public housing residents, and a significant social determinant of health is violence. So this map shows the location of the public housing primary care health centers across the country and the corresponding rates of violent crime in the county where they are located. And in this case, violent crime refers to murder, rape, robbery, and assault. And as you can see, these health centers are more likely to be in areas with higher rates of violent crime. In fact, there is an average of 508 violent crimes per 100,000 population in counties where PHPCs or these health centers are located, compared to just 386 nationally. And more than half of all PHPCs are in counties within the highest quintile of violence. Violence tends to be higher in communities where there are limited economic opportunities, where there are higher concentrations of poverty, unemployment, and then there's limited access to health and social services available to residents, and racism and stress. And these factors can sometimes tip people into acting violently or engaging in criminal activities, or they can contribute to the cycles of violence that pass from one generation to another. So we aren't just talking about violent crimes that was described in the previous slide, but also about things like domestic violence and gang-related violence. Directly experiencing or witnessing violence of any type, whether it's physical, sexual, or psychological, is associated with an increased risk of mental health and behavioral disorders like depression, PTSD, anxiety, substance abuse, suicide. But violence is also associated with the development of major non-communicable diseases like cardiovascular disease and lung disease and diabetes. And children are very sensitive to the effects of violence. More than 60% of youth under the age of 18 have been exposed to crime, violence, and abuse either directly or indirectly. And there's a large body of evidence that shows that as the number of traumatic events experienced during childhood increases, the risk for depression and substance abuse and other problems in adulthood increases. And we can see some of that when we start to examine the health status of public housing residents. The Department of Housing and Urban Development has worked with the CDC to link data from the National Health Interview Survey with HUD data on individuals that are enrolled in public housing, Section 8, or housing choice vouchers. And the data shows that adults that receive any type of housing assistance from HUD have higher rates of chronic health conditions and are greater utilizers of healthcare than the general population. They are more likely to be in very poor health, be overweight, be disabled, have diabetes, be smokers, have asthma. But what I want to draw your attention to is that these differences are quite significant. And if we look at some of the mental health indicators, such as psychological distress or distress with mental hardship, and those just refer to feelings of anxiety, depression, and hopelessness, and when those feelings interfere with daily activities. So if we look at those indicators, we can see that public housing residents are not only more likely to report those feelings of distress compared to the general adult population, but they're also more likely to report it compared to other low-income renters, which indicates that there's more than just economic status at play here. So given all of this information, and we know that efforts to prevent and respond to violence at the individual level and across communities and across generations is critically important for health centers that serve public housing residents. So given that, we engaged in a qualitative research study to highlight best practices and examples of violence prevention and intervention programs that health centers can implement in their communities. What we did was we identified and targeted a group of health centers that are located in high crime areas, and we asked them about the notable programs at their health centers. We interviewed the staff, and we conducted some background research on the area to get a sense of the community and the context of the neighborhood. And then we analyzed the interviews and identified some of the overlapping themes and strategies that the health centers were engaged in to address violence. Here are some of the questions that we asked. We asked, what are the types of violence that are the most pervasive in your public housing community? Is it gang-related? Is it domestic violence? Is it crime? Is it violent homicide? Have residents exhibited an increase in mental health illness or symptoms because of the violence in the community? What are the major violence intervention and prevention strategies that are delivered at the site? Who are the partners and the players that are involved? And what have the outcomes of those programs been? Are there any successful strategies or initiatives that have been particularly effective among vulnerable groups, such as children and families? Have there been any efforts to enhance mental health service delivery in response to increased violence in the community? And then finally, what are the expectations of these programs by residents, by housing authorities, health centers, or other decision makers in the community? So we narrowed down our original list and included 3 health centers that were included in that case study. One was Whittier Street Health Center, which is in Boston, OIC, which is in Rocky Mount, and then Genesee Health System, which is in Flint, Michigan. And we're very grateful to have speakers from 2 of the health centers to discuss their programs with you all today. So I'm going to turn the presentation over to them, but first we have a polling question. So Peter, can you go ahead and announce that? And I think the polling question is, are you currently planning or implementing a violence prevention or intervention program in your house, in your organization? And Fide, can you please announce the answers to that poll? I'm sorry, I can't hear you, Fide. Why don't you switch to Brian and go ahead, let's go ahead and get his presentation started.
Hello. Okay. My screen. There. Can everybody see the Genesee Health System presentation at the time?
Yes, we can see it. Thanks, Brian.
Great. So I'm from Genesee Health System, and we have also, as a part of our overall health system, a federally qualified health center, Genesee Community Health Center. A little bit about Genesee Health System. As I mentioned, we do have 3 federally qualified health centers under our umbrella, operating in the city of Flint within Genesee County. The center city location is in downtown Flint, and it primarily serves the homeless population. Our Atherton Center is located within the Atherton Public Housing Complex and serves the public housing population. We also have a mobile unit that has 2 offices within the RV, and that serves as a crisis deployment unit and to local senior apartment complexes, as well as our local shelters, health centers, and missions within Flint and Genesee County. Of the individuals served by the health center, Genesee Community Health Center, there are approximately 1,000 patients living in or near the public housing site, Atherton, and more than 3,500 patients living at or below the federally poverty level. Most of our patients are on Medicaid, and around 5,000 patients have mental health or substance abuse disorders. Genesee Health System operates all of the behavioral health services for Medicaid and uninsured residents in Genesee County. GHS, Genesee Health System, is the specialty behavioral health treatment and crisis service provider to more than 10,000 individuals per year, and over 6,000 individuals receive substance use disorder treatment per year. I put a little graph of demographics in regards to the Genesee Health System, mainly the health center itself. And on the left-hand side, you can see just, again, over about 1,000 individuals are in public housing that we serve. Over 3,500, almost 3,600 are at poverty level. 318 uninsured, just about 3,200 on Medicaid, just over 500 on Medicare, and just under 500 are dual. The largest portion of the population by ethnic group is whites at just over 2,500, and then followed by African Americans just under 1,300, and then a Hispanic population at 465. Of over the 5,000 people we serve, you can see almost the majority of all of them report either a substance use disorder or some type of psychiatric issue with depression or anxiety. 2,100 have self-identified substance abuse disorders, and just under 3,200 a depression or anxiety issue. Overall in Flint, the population continues to decline. At one time, Flint was the birthplace of the Union and General Motors, General Motors had a factory called Buick City that employed over 50,000 individuals alone within that one factory. Now you can see the population is under 100,000, with nearly 42% of the population living in poverty, 24% is unemployed, and we're showing 765 individuals per 100,000. Yes, that is in the crime. African Americans is the largest portion of the population, followed by white individuals. So some of the things that is happening in Flint and led to some of the initiatives of intervention and prevention that we are currently doing is the opiate epidemic. In fact, it has hit our state very hard. I'm sure it's doing the same across the nation. Currently, we have seen a 30% increase in overdose deaths statewide between 2013 and 15. In fact, you'll see later in this presentation that we have training, and we provide that to the public as well as different groups, the law enforcement agencies, schools, substance abuse providers, hospitals, etc. The Narcan kits, it's a treatment for overdoses, and at this time it's a regular occurrence to see somebody overdosing at least once a week in one of our facilities. We have initiated that intervention of training our entire staff and having Narcan kits available at every location. It's in a first aid kit, just like our fibrillator or bandage would be. You can easily access that and immediately provide that intervention to anyone overdosing. Flint is one of the top 10 cities in Michigan to report a higher number of opiate-related deaths. We've struggled, as I mentioned on the previous slides, with high poverty and unemployment. These rates of substance abuse, coupled with the sizable homeless population and the number of abandoned houses, has created a difficult environment in the city. This has resulted in a large drug-related violence. We are located, our main office is in downtown Flint, right on the outskirts of the business district, and I can look out my window at this time and see 50 to 100 abandoned homes surrounding me. At any given time, they're filled with individuals living that are homeless. Even though we have shelters and other opportunities available, many of them suffer from psychiatric illnesses that they often find difficulty remaining in shelters or missions. Another large population living in these abandoned houses are individuals with drug use and substance abuse. Again, I can see most days somebody using illicit drugs on the porches or in the houses that are in the neighborhood. All of these homes obviously don't have any utilities, water, heat, electric provided to them. So that has created a blight in the area and difficulty trying to serve. You'll see later the outreach that we do and how much we've reached out to these types of settings. Flint is one of the most violent cities in the United States. It was always rated within the top 5 for the last many years. In addition to these other factors, you may have seen, read, or heard in regards to Flint's water crisis. The water was tainted with lead, and for over 14 months, though it was known that the lead was in the water and dangerous levels that was being absorbed by the population, it was not reported or informed to the community. Therefore, all of us continued to use the water and received the lead through that source, the water. in addition to that, the water also had a higher than normal Legionnaire bacteria in it, and we've increased the actual Legionnaire deaths in the city by double. In response to the water crisis, we have developed a neurodevelopmental center for excellence. We're assessing over to 28,000 children with neuropsychological assessments in the city of Flint and or who came in contact with the water. We currently are the designated water entity for Genesee County, and most grants flow through us, over 30 water-related grants. You'll see here that over 20,000 successful contacts of outreach has been done by staff. On this next slide, you can just see some of the breakouts of how those are being done. And even to this date, just in the past couple months, November, you can see we've even reached out more because of the need to try to register individuals for services and reach out to them. We are the target case management entity trying to provide services to them. So we reach out in a variety of ways through community events, help centers, outreach sites, and just canvassing, just going from house to house to house, knocking on doors, trying to provide literature, install filters on individuals' water faucets throughout their houses. Violent prevention and intervention. So some of the things that we have done is created a sobriety facility, a social recovery overnight center. It's a risk and harm reduction. We've often had many discussions about this individual has, showed up for 2 weeks straight, intoxicated or using drugs, should we tell him he can't come or she can't show up anymore? But we've noticed, and from some interactions with law enforcement, we've seen some domestic violence numbers decrease, and we do believe that giving a environment for somebody to come to and not a better term for it, but sleep it off, really provides a risk and harm reduction, not only to them because they have somebody watching and oversight of them, but to individuals that they come in contact with. Oftentimes, violent situations do erupt when somebody is under the influence and intoxicated. As I mentioned, we provide free training and Narcan kits to the general public. During a recent outbreak of a substance use disorder, we had over 13 people overdose in a 24-hour period within a 4-square block area. I deployed our health navigate gave coaches to that area, and we sat in Dollar General stores, churches, missions, handing out these Narcan kits. To my surprise, a large majority of the people asking for the kits were elderly grandparents. Basically, they said, not on my watch. I'm not going to let my grandson, my child, my nephew, my niece overdose when I'm around. So even in their later years, in their senior years, they took control of an awful situation that were, again, an epidemic of overdoses that's happening, and they themselves are taking control of those situations. We also created a subacute detox diversion center in partnership with the emergency rooms of the local hospitals. This diversion program developed for individuals entering the emergency room that we can direct them to a subacute detox provider center at that point. Many times they were left to sleep in the weight rooms, or many of them were put into psychiatric inpatient beds. Most were just sent home because there was no actual issue that they were facing. But this will direct them right to the centers and put them in an appropriate level of care, and it serves as a no wrong door entry. We catch them at the point of crisis, and oftentimes that's when they're the most willing to look at change in their own life. So we've also linked to a medication assistant program, and currently the health center, we have created 3 different MAP programs. Substance, we're using Suboxone and Vivitrol with social workers attached to the prescribing practitioners, as well as health coaches and peers. These programs are successful, and we've seen a very high rate of success for the individuals entering into those programs. In addition, we also have board-certified psychiatric personnel, nurse practitioners and psychiatrists, that we provide medication assistance in the form of psychiatric treatment. The social workers are all also duly trained so that they can present and provide treatment for both the psychiatric individual as well as the substance use disorder individual. We've put social workers and embedded them in the emergency rooms, jails, and law enforcement, driving and attending with officers. And we've believed that this has helped to curb the incidence of domestic violence and the eruption of occurrence with alcohol and drugs, as I mentioned earlier. We've also created drug courts, mental health courts, and veteran courts. These staff are embedded within these courts in conjunction with law enforcement and the courts. We hold jail and pre-hearings right in the jail at 6:30 every morning, where we cross-reference the booking report against our admission reports for psychiatric treatment as well as substance abuse. And this way we can get them out a little quicker from the jails and have a situation where we can provide treatment through court orders and services that way. During a recent study, Michigan State University showed a reduction in recidivism and savings for these agencies, mainly us. We studied individuals and the number of admissions within the jail system a year before, as well as detox centers and psychiatric hospitals. The majority of those individuals, almost 80%, had 3 or more contacts with jail, psychiatric hospitals, or substance use disorder facilities. We watched them for 3 years, the year they were in the mental health substance abuse courts and 2 years after, and the majority of them had 0 to 1 after that. We also saw a large reduction in the cost, almost $500,000 per year in the jail alone, and in psychiatric treatment, the cost dropped from about $10,000 average of these individuals per year to $4,000. So even with more intensive services, they showed a lower cost, even though they received more services. It wasn't the high cost services of psychiatric inpatient or detox jail. And it helped with the overcrowding of the jails. We have also worked to invent a program called Great Lakes Connect, where we can make referrals online there for transportation, food, clean water, child care, a variety of social deterrent issues. We've trained all of our staff, as well as working with the schools, law enforcement agencies, and our substance use disorder treatment providers to train them in Narcan. The hiring of health coaches as navigators has been a great resource, as well as the HRSA grants for the access and increase in mental health and substance use disorder, the AIMS grants. We employ social workers and peers, as well as case managers to fill in the gaps with housing and public housing referrals and coordinating that service and treatment. And we do believe that the skills of the staff result directly in improving the overall health of the patients that we serve. Some of the key challenges and strategy was to train all of our staff on de-escalation, as many of these individuals, again, are coming in with psychiatric illness or substance use disorders and intoxicated. Provide coordination of treatment to local health agencies for health, food, clothing, medication. Always remember good customer service, treat people with respect, have your facilities look like a place that they deserve to be at and be respected in. Have a private space away from the public that individuals can be moved to in case it erupts to a violent situation. Address the social deterrence. Help individuals. Most of the time, that's what they're looking for and really need, along with the health care that they're coming to receive from you. And again, I can't stress how important training individuals with Narcan kits for substance use disorder. It's a regular occurrence that our staff now has to become involved with. That's all my slides at this time, and I appreciate everybody listening to me. Thank you.
Thank you so much, Brian. And now we're going to hear from Bridget Luck.
Hello, everyone. This is Bridget Luck from the great state of North Carolina. So I just want to share a few things with you all about the work that we are doing here in Rocky Mount and how important partnerships are in this work of community and assisting residents who are underserved and in high poverty areas and high crime areas. So OIC, for short, for Opportunities Industrialization Center, last UDS year we served almost 9,000 patients with a 40% Medicaid and 30% uninsured rate. We had 21,000 medical encounters. Our service lines include primary care, dental, and behavioral health. We also provide care on a mobile area health unit. It's really an RV that's been updated to be a clinical setting on wheels. We also have a community health education center, and we just recently opened a school-based health center. The reason that we are even in healthcare now is because of our core work, which is education and training. We provide job training, soft skills, hard skills, and actually on-the-job training for individuals who are currently unemployed and are seeking additional skills to improve their careers. And our students at that time were not able to get primary care. So we then in 2005 began the healthcare field, and it has grown by leaps and bounds since then. So we're located in the city of Rocky Mount, and we are actually a city split into two counties. We serve residents in Edgecombe and Nash counties. For those that don't know much about Rocky Mount, we're located just about 45 minutes east of Raleigh, which is our state capital. Our population here in Rocky Mount is about 55,000, with 22% living in poverty, and our median income is around $37,000. I do want to take this time to acknowledge the work of the late Jim Burnstein, who was mentioned earlier that I'm a part of a Jim Burnstein Fellowship, and because of the work that he has done in North Carolina and also across the nation, there is a scholarship or a fellowship in his honor to help rural areas and rural leaders have projects that can improve health outcomes. So Jim Burnstein was the founder of the president of the Foundation of Health Leadership and Innovation, and his life was dedicated to improving health care in rural communities in North Carolina. So those that live in public housing and those that are homeless, those are the underserved communities that he thought it was important for us not to leave behind as we change the culture of health in our state and in our nation. And a part of this fellowship allows leaders to be identified and supports the work that we do in outstanding individuals around health services in rural communities. So how do we do this work? Initially, when we're developing programs, sometimes we think from the top down, but what we wanted to do was actually start the conversation with community members, those that were impacted by and lived in public housing and also experienced homelessness. We wanted to talk to them and see what they thought about the services that we were providing. Were they good? Were they bad? What additional things that they need from us as health service providers? So we had a series of 3 focus groups for those that were experiencing non-permanent housing. And the focus groups averaged for about 12 participants, and these were held last year in March, in July, and also in August. So the first focus groups were actually residents who were in non-permanent housing. So those that were in co-ed shelters, those recently released from prison, and those that were in substance use facilities. And for our population, we do actually serve a number of individuals who have been recently released, what we call the re-entering citizens, who are trying to change their lives and reduce recidivism. The second group was located in the Bassett Center, which is our local shelter for families and children. And then the third focus group actually focused on service providers that provided services in an array of services in areas to individuals who were homeless or in non-permanent housing. And this process was about 6 months long, and we gathered so much data that it was almost overwhelming. So we tried to pull out some common themes of the data of the participants, and one thing that came out was the access. Number one, understanding what services were available, the lack of primary care services, the lack of comprehensive social and emotional support, and then advertising. How do they know what's available? Just because we have a building does not mean they know it's there. So how do we make sure that the community knows what we have? Just like a number of health centers, we are in a healthcare shortage provided area. So how do we make sure that we do the best that we can with our services and be unique and be and have that approach to make sure we get them care in the most vulnerable populations? Some of the root causes of some of these things for the residents were substance use, criminal background, general poverty, generational poverty, access to a living wage, access to basic support needs. So what I learned is that with housing, their number one priority is to make sure that that person gets from non-permanent housing to a permanent housing situation. But what we have to figure out is how to have those wraparound services and support services that they don't end up back in a non-permanent housing situation. And what I also want to share is that we had a number of partners that you see listed here, the City of Rocky Mount, our local Rocky Mount Housing Authority, both school systems, because we actually do serve the same patients, just in a different discipline. So they may go to the hospital, they may be in the homeless shelter, they may be in various areas, but we all have the same demographic of patients, and it's important for us to make sure that we're not duplicating services, but we're actually coming together to collaborate to make sure that we improve health access. A number of things came out in the primary data, but in the secondary data, something that was very important was the fact that how are we utilizing law enforcement in a mental health crisis? So what is the appropriate usage of mental health mobile crisis instead of law enforcement to access emergent mental health services and assessments? So, normally people, when they don't know what's available, they call the police and they think things are just emergent when it could be a mental health crisis. So how do we have those conversations with community and family to let them know that you have this resource of mental health mobile crises, as opposed to calling the law enforcement and utilizing those resources which could be used for another reason. So we're working on trying to quantify the data. So we're looking at factors such as the call volume. Where are these calls being dispatched to? What is the reason for the calls? What is the number of involuntary commitments that have been issued in our counties? Because those things can help us try to dissect the data to see where we need to dispatch services. And so our next steps would be to educate the community on the use of mobile crisis in order to access emergent mental health services. A lot of it is trying to reduce the stigma regarding mental wellness. As an organization, we'll continue to seek operational and capital funding to support our services. We currently do have a mobile unit, but we know as services and access increases, the demand increases, we'll need additional units to deploy in the community. And we also want to provide printed material and also have the conversation around things that are available within OIC and also within our community. But one other important piece is that we are actually engaged in conversation with the City of Rocky Mount and the police department to make sure that he's aware of the things that came out from the community assessment, and then how do we use that to better serve our community and better leverage our resources. And that concludes my presentation.
Thank you so much, Bridget. I think we have another polling question. I couldn't hear Fide earlier, so let's see if Fide can get on and try the polling question. There we go. I can see it now. So the question is, do you collaborate with law enforcement on violence? Oh, wait, that was the first one. Sorry, we're having a little bit of technical difficulties with these polling questions. Fide, why don't you just make me the presenter and I'll wrap this up and then we can go to Q&A. Okay, thank you so much to the presenters for discussing their projects and for contributing to the case study publication. I just want to summarize some of the lessons that we learned in the case study research, and then we can go to the Q&A section. And the first, and perhaps the most obvious lesson that we identified through the case study interviews is the importance of thoughtful engagement with the community. And, you know, programs that are offered at health centers have to be linked to the needs of the patients, whether it's clinical or supportive, or those that address the social determinants of health. And the most direct way to identify those needs are through discussions with residents. And that really relies on open communication and trust with the patient population. Some of the health centers have found that cultivating those relationships with the community can take a lot of time and take a lot of effort. And some strategies that they've used is creating a regular presence at community events, you know, holding family-focused activities, and staying in the sight of the community, and also being conscientious of work and school and community calendars to make it easy for community residents to engage, to participate in health center activities. The next lesson is the importance that health centers react to, be responsive and react to the trauma needs of patients comprehensively by utilizing a trauma response model that incorporates a multidisciplinary team approach to providing care. In environments where community violence occurs regularly, health centers should consider staffing teams to care for the continuum of needs that come across the families and communities when a violent event occurs. The health centers in this case study have all had an integrated behavioral health and primary care services offered at their sites. So understanding that relationship between violence and mental health and substance abuse is key to delivering the appropriate suite of services that patients need, the public housing residents need. And then finally, the last lesson learned here is that public housing residents need a wide range of health and social services to address all of the many social determinants of health that impact their lives. So building relationships and partnerships with other community nonprofits, whether it's in health or housing or other social service agencies, can create a collective that can draw on all of the diverse skill sets of those individual organizations to address those needs and kind of fill those gaps. But it also can increase opportunities and introduce new or leverage existing resources and funding streams. All of the health centers that participated in this case study created these mechanisms to communicate with community partners on a regular basis, either through task forces or working groups. And this helps address and kind of bolster their efforts on violence prevention or intervention, but it also creates this infrastructure that's necessary to collaborate on other ongoing or emerging issues in the future. So now it is time to open it up for question and answer. I'd like to remind everyone, if you'd like to ask the presenters a question, you can submit it through the question box on your control panel. And if you're dialed in through your telephone and you want to verbally ask the presenter a question, just use that raise hand icon and Fide will unmute your line. So the first question that we received was, Were public housing residents involved in the focus group? So this is a question for Bridget, and if Bridget, if you are unmuted, you can answer that to the entire audience.
Thank you for your question. Yes, there were residents in the public housing community included, and also the CEO of the local housing authority was also present.
Great. And then there was another question that was posted in the chat that says, you may touch on this later, but can you speak to the link between the lead in the water and link to crime rates and also to mental health, anxiety, and depression in the future? So I can start with that off and then maybe pass it on to Brian, but the evidence, the public health evidence base shows that, you know, there really is no safe level of lead in your blood, and any levels of lead in your blood have an increased risk of, you know, neurological disorders, developmental delays, problems with hearing and speech, and behavioral problems, including juvenile delinquency and criminal behavior. And there have been some longitudinal studies that looked at the relationship between lead exposure both in the womb and during early childhood, and has shown later adult arrest records, like a correlation between lead exposure and criminal behavior and arrest. And Brian, is there anything else that you'd like to add to that?
That's very correct and accurate. This is one of the reasons that there was so much anger initially in this community, a very poor area that's already filled with a lot of violence and crime. It was felt that you know, it was neglected or wasn't informed to us just for some of those reasons, and later in life, juvenile delinquent type behaviors are seen with that type of lead exposure as well. The issue is mainly with children. They were exposed, and during their developmental process that can affect it tremendously. So we were providing services to individuals up to age 21, as well as any woman who was pregnant or recently had children. We continue to provide services to them as well. The problem is that lead, though it's in your blood system for 30 days after being exposed, it does settle within the bones. So it maintains with you for pretty much a lifetime. And the other issue is that it wasn't a one-time exposure, that it was continuous over a 14-month period. So that presents even a higher risk and danger to us. That's why the neuropsychological developmental assessments are being done, so that we can get a baseline, and hopefully we can continue those assessments so we can track and provide services and implement target case management as well as other forms of treatment and therapy, probably over the next generation of individuals that reside here, as well as throughout the state and other places.
Great, thank you so much, Brian. Fide, I'm having trouble hearing you, so if you can hear me, are there any audience members that have their hand raised and would like to ask a question? Fide says yes. Through the chat. Can you unmute their line and allow them to ask their question? And can you just let me know what their names are so I can let them know that their line is going to be unmuted. And while she is figuring that out, I'm going to ask one question to Brian, which is a kind of a question that we always get from health centers and organizations that are trying to implement new programs, is about funding, about resources for these programs. And particularly when you have a staff member that's involved in spending time in other places, like through your drug courts and your mental health courts. Can you talk a little bit about the funding streams and resources that you have available for that particular program, and then also for these community health navigators that you use for outreach?
Yes. Well, there's a couple ways of doing that. Some of the court programs, for instance, the mental health court, we were the first ones in the state to do that and recognize the need for it. And my arguments of the reduction in overall cost of care per case became true when Michigan State University actually did the research and followed us for a 3-year period. That prompted the State Court of Appeals for the state of Michigan through the Department of Justice to reach out to the federal level and get grants that now support several, well, there's 19 mental health courts, I believe, operating currently with another 6 to come online, and they support a variety of different positions from court clerks to liaisons to different services. For instance, I actually funded the initial defense attorneys to provide services and support to the mental health recipients. Drug courts have been around for a long time, so there's a lot of grants out there. Reduce the overall cost per case that happen in regards to our services. So sometimes you have to take a leap of faith and know that what you're doing in the long run not only increases the quality of care or reduces, in many of these cases, violence or a prevention program, but in the long run, it will reduce the overall cost per case. And we were fortunate to prove that and show that effects. Oh, Jesus, they cut me off or something.